Good morning, my name is James Stager, and today I'd like to do another video on my EUPLOID embryo series. This one is about the Blastocyst Expansion grade and the early serum beta hCG levels. It's based on a publication that appeared in Gynecological Endocrinology in late September. The implantation in single euploid embryo transfers, the role of Blastocyst Expansion grade and serum and early serum beta hCG. So the object here was to ask the question, was there an association between the Blastocyst Expansion grade and the early serum hCG levels in pregnancies after a single euploid embryo transfer? Just by way of background, as you all know, the beta hCG is produced by the trophectoderm and then the placenta to support the production of progesterone by the corpus luteum. After the first trimester, the hCG starts to decrease and become quite low as the placenta starts to produce its own progesterone. You see it rises very quickly to around about 12 weeks of pregnancy, and then it falls away very quickly by week 24. But there is an estimate. You look at the probability of pregnancy against the rate of rise, or basically the hCG levels on day 9 post-transfer, you can see that there's a fairly linear relationship between the value of the hCG on day 9 and the likelihood of a viable pregnancy. So it rises roughly in an exponential manner the first few weeks, but hCG mimics LH and binds to the same receptors as LH in the corpus luteum, the transformed ovulated follicle. But note, artificial FET cycles do not have a corpus luteum, and the hCG performs no function in these cycles other than as a marker for pregnancy viability, or at least I think so. So quoting from the introduction of the paper, embryo implantation begins with a loss of the zona pellucida, a process known as hatching, which occurs 1 to 3 days after the embryo enters the uterine cavity. The citation here, a review of the mechanism of implantation, granted in 2017, is an excellent paper to read. Human chorionic gonadotrophin, hCG, is produced by the implanting trophoblast and serves as an early and reliable marker of implantation. hCG measurements after a single embryo transfer remain the earliest predictive indicator of pregnancy outcomes in IVF cycle. See this quotation here. Specifically, parameters such as beta hCG doubling rates and reaching specific thresholds on day 15 post-transfer are often considered a reliable predictor of live birth. See the citation here. So the question the authors asked then is a natural one, and I think it's quite a good one, is if the value on day 9 and day 12 post-transfer are an indication of the health of the pregnancy, does the hatching stage influence the observed value? Interesting, one study determined that hCG values, predictive values for live birth, were different between day 3 and day 5 transfers, 94 for day 3 and 160 for day 5, but not for multiple pregnancies listed at this stage. But we do know that beta hCG can be detected in spent culture media for blastocyst culture, and that hCG is therefore at the time of implantation. But it does take a while for it to be detected in sufficient quantities for the women's serum and also to be available at the corpus luteum. And just as an aside, I had to put this in, just a word of warning. One of the many cases I come across after 50 years of embryology, which are quirky. We had one case, and one case only in 50 years, where the hCG never rose above 200 international units per mil, and they still developed a healthy pregnancy. It just petered and rose really, really slowly to around about week 10 and then fell away. And supported by progesterone. And so in this way, just to remind everyone, the hCG measurement is only the immunologically reactive part of the hCG for the assay and not necessarily for the bioactive part. So back to the paper. So in this paper, they looked at a retrospective study, of course it is, of 8,500 single euploid transfers, which is a lot. Blastocysts were categorized as hatching, about a third of them, or partially hatched, about 2/3, based on their expansion grade after warming and just prior to transfer in artificially managed cycles. hCG was measured on day 9 and 11 post-transfer, and when they applied multivariate logistic regression, it adjusted for confounders which included age, ovarian reserve, that's AMH, embryo morphology, year of treatment, and day of biopsy. Okay, I'm sorry about the color. It's meant to sort of, this is actually meant to indicate my comments, not the author's comment. Just an aside, you have to remember that this is not a normal implantation environment. If hCG can be detected, actually I apologize to the color, it looks terrible now. If hCG is detected in culture media, then it may be present in the utero at least a day, or at least even after day 3 transfers before hatching. There is this potential for some form of endometrial response to localized hCG that may reflect the presence of a viable embryo. As in the case described in this article, first the endometrium detects hCG as at the very moment of transfer, and this may influence the timing and response and development and implantation and attachment. Okay, so here's the data. This is what the paper is all about. It's not earth-shaking, you have to admit. These are the box plots of fully mature blastocysts, hatching blastocysts, and fully hatched blastocysts on day 9. That's the typo here. That should be day 9, I think. And you can see there's a wide range of values, but the mean values are only just subtly different. But statistics being statistics tell me that the median hCG level was significantly lower for completely hatched blastocysts compared to partially hatched blastocysts, and they're highly significant. And which is amazing considering these outliers here. These values are around about 180, 120, 130, 140, but some of these values are 6, 7, 800, and surely they will be having significant influence on the mean distribution. But if you go to day 11, what they call day 16 there, this one here, the difference persisted on day 11 transfers, where the partially hatched blastocysts had a significantly higher value than the fully hatched blastocysts. 357 compared to 327. However, multivariate regression analysis remains significantly associated with the lower hCG on day 9, but not on day 11. In other words, the statistical value isn't really reflecting what you'll normally be seeing in value, and being able to use that as any form of thing is probably ambitious. So they concluded completely hatched blastocysts had with an expansion grade 6 were associated with the lower serum hCG compared to partially hatched blastocysts on date with expansion grades 4 and 5. Incorporating expansion grades into prediction models could enhance decision support for tools for IVF patients. Okay. However, they did produce 2 interesting tables. One was that the day of biopsy was significantly different between completely hatched and partially hatched. So I assume that these were all partially or unhatched blastocysts when they were biopsied. But let me just okay. They were different. So they're completely hatched. Most of the embryos were on day 5. They were biopsied, but most of the partially hatched blastocysts were on day 6, which I thought was kind of interesting. The difference in AMH, 22.3 to 2.6. There's not an awful lot, but statistically it's highly significant. And so there is something there about ovarian reserve and the rate at which the embryos are developing. And as we know that the difference in hCG, 118 compared to 133 for partially hatched. And on day 11, 290 compared to 327. That's also significant. So if you saw an embryo with a hCG of 110 on day 9, you would probably associate that with the hatch blastocyst. But I mean, it's fairly petty, really. But the more interesting table was this one. So both hatched and completely hatched blastocysts had the same sort of doubling rate. And the clinical pregnancy rate, 83% compared to 83%. Excuse me, my buddy phone's probably around the twist. Not significantly different, but that is an amazing value. But look at this, a live birth rate, 68% for completely hatched, 68% live birth rate compared to 71. So the clinic should be applauded for having those sort of success rates. It's not statistically significant, 0.07. Well, it's significant for everything but the hand of God. So I mean, basically, the hatched blastocysts, I think, had a slightly higher live birth rate, and they had a lower clinical pregnancy loss rate. So interestingly enough here, this was significantly 15% of hatched pregnancies failed, whereas 12% of partially hatched blastocysts failed. And I might like to make the point that if you were transferring unselected embryos, the miscarriage rate is often double that. The pregnant biochemical loss rate was kind of similar, but this also was interesting. This wasn't significant, but this is the twin pregnancy rate. This is identical twinning rate. A single embryo in a artificially constructed cycle, so there's no spontaneous ovulation. 2% in this case, and 2.5–3% of partially hatched blastocysts resulting in monozygotic twinning. I actually thought maybe it might have been the other way around, but this one does suggest that in a bigger study, it might well be that partial hatching is associated with monozygosity. So what's happening? In other studies, we do know that hatching blastocysts have outperformed hatched blastocysts, supporting this observation. We also know that day 5 blastocysts have outperformed day 6 in terms of live birth. And there's also fast developing blastocysts which get to which start to hatch very early on day 5, also perform very poorly relative to the 508 gold standard. So in conclusion, the author said, completely hatched blastocysts were shown to have slightly lower early serum hCG levels and a higher rate of early pregnancy loss compared to partially hatched blastocysts, despite having comparable frequencies of achieving a doubling of hCG in the 48 hours. So my comment, and thank God I haven't done it in red, it strikes me that maybe the zona pellucida is providing some protection to the blastocysts, especially the blastocele. We know the blastocysts that undergo multiple contractions, that is leakage, and re-expansions perform poorly compared to blastocysts that do not contract. And once again, the optimal embryos to transfer is looking for one that has started to hatch, that is proof it can hatch, but without having completed it. So something somewhere between these two is probably a bit more advanced than that, not quite as advanced as that. No, that's a mouse. I know. So these findings suggest that the complete loss of zona pellucida prior to transfer may alter embryo endometrial interactions or possibly expose the complete blastocyst to oxidative stress during culture or after transfer, impairing the trophoblast function and reducing implantation potential. Whilst the associations were statistically significant, the absolute effect sizes were modest, and the clinical utility of expansion grade as an isolated predictor of outcome appears limited. And one final comment, this is my own thing, once again, I haven't done it in red, so there is a God. Final comment, this paper is about hatching and implantation. We always assume the embryo hatches completely and then implants. We know that the human embryo hatches from the zona pellucida and then it attaches above the inner cell mass, but not where the biopsy pore is. One wonders if the hatching blastocyst provides an orientation for attachment as compared to hatched blastocysts. I think this area is not well understood at all, and we need to be looking for more papers such as these, which will explore the very concept of hatching and implantation in a more focalized opinion. And the advantage of working with euploid embryos is, the embryos all have the potential to continue development. So it's a good paper, even though I thought the data on it was fairly minimal and the conclusions were fairly modest. There's always a good paper that makes you want to think a bit wider than the results. Now that I'll call it quits. My name's James Danger. I'm an embryologist with more than 50 years experience. I'm not a medical person, and this information is not medical advice, but it may help you in knowing what questions to ask about your treatment with your doctor, and maybe to help in understanding the advice that you receive. If you like what I'm doing, become a subscriber, press your like. And I also just like to make everyone aware of my thirdaid.com website, which is an online EQA program and training program for IVF in andrology and embryology. And for that, I'd like to thank you. I know IVF is a personal journey that involves the action of many steps and many staff and many techniques, and it helps to understand all aspects of that journey. It's not easy for clients coming through to understand it. I hope this information may be of value. If you like the information provided, please tell other clients about the service and please subscribe. And that, I think I'll say au revoir and thank you for listening.